Good morning, good afternoon, good evening, wherever you are in the world. Welcome to the Microsoft Cloud Digital Series. My name is Kevin Chia. I'm an industry marketing manager here at Microsoft, and we had a great show in store for you today around how Canadian hospitals are tackling backlog surgical waitlist times with innovation. Before we get started, a couple housekeeping items. First, on the left side of the screen, we have our live Q&A chat. If you got any questions during the session, I highly encourage you to ask in the chat. Questions are moderated by our team and will be responding in real time during the live portion of the webinar. If you're tuning in on demand, you can reach out using some of the resources below. Second, everyone's going to get a copy of today's recording within 24 hours via email of this webinar. If you haven't received that message, check your junk mail, as you might want to go back and revisit some of the topics we explored today. Third, on the right side of the screen, you're going to see our survey. Love the content, hate the content, wish we would cover another topic in the Microsoft Cloud Digital Series healthcare webinars? Let us know. Finally, this webinar has been closed captioned. You can actually turn on this feature on the bottom right-hand corner of the media player. With that said, that covers our housekeeping items. I'm going to pass it off to Peter Jones, our industry executive in healthcare, to start us off. Sit back, relax, and we hope you learned something new today. Let's roll the intro.
Good morning, everyone. My name is Peter Jones. I'm the industry lead for Microsoft Canada, focused on healthcare. With me today is Dr. Chris Simpson, who is going to talk to us a little bit about what he is doing with around addressing wait times and being able to help deal with surgical wait time. So welcome, Chris, and also with me is John Sinclair, the president of Novari Health. Gentlemen, good morning.
Good morning, Peter. Good morning, Chris.
Good morning to you both.
So just to reiterate, Dr. Simpson is actually the CMIO with Novari Health, and he's also a practicing cardiologist. And John, as I mentioned, is the president of Novari Health. And, you know, we're seeing a lot of challenges with wait times and surgical wait times in Canada. I think COVID-19 has further caused further delays in a delay in surgical procedures across the country. Some of the stats I've heard is that we are probably set back about 1.5 to 2 years of potentially trying to clear that backlog. So Chris and John are going to talk to us a little bit about what they're doing to address that in Canada. But let me first talk to you a little bit about what Microsoft is doing and how we're helping our partners build solutions on Azure and really be able to help address some of those challenges we're faced with in Canada. We've actually introduced what we call a Microsoft Health Cloud. And really what that does is it enables really the infrastructure and technology that a lot of our partners can actually leverage, really around enhancing patient engagement, empowering healthcare teams, and really getting good insights on patient data. And you'll see an example of that today through what we talk about with Chris and John. But Chris, what I wanted to do was have you take us through a couple of examples of what you're seeing out there when we deal with surgical wait times. So maybe you could just present some of those scenarios that you've seen.
Sure. Well, there are three scenarios I thought I would discuss that are kind of variations on the same theme. And as you said in your introduction, one of the things that has really posed the issues of wait times very starkly in Canada has been the COVID crisis. You're all aware, of course, that Canada hasn't always been the best at wait times to begin with. And then suddenly when our capacity was greatly diminished because of the COVID crisis in wave one, the wait time issue has become exacerbated. So just to give you some practical examples, this first case is a patient of mine, actually, a 59-year-old woman who has recurrent atrial fibrillation. Atrial fib is a heart rhythm disorder that makes the heart go very fast and irregular. She'd been waiting already before the COVID crisis hit for 6 months for a procedure called catheter ablation. This is a procedure that promises to eliminate her symptoms and allow her to get off the heart medications that she was on to control her heart rate. And these meds made her feel really tired and draggy. She was scheduled for the procedure in April of 2020. Very much looking forward to the procedure because the meds made her feel nauseous and tired all the time. They weren't really working that well anyway. She was still having episodes of her heart just taking off like crazy about twice a month. And not infrequently, she was coming to the emergency department because that was the only place where it could settle down. So extraordinarily disruptive to her life. And then on March the 20th, she got a call from our office informing her that because all non-essential, and I'll put it in quotation marks, non-essential and elective care had been put on hold, her procedure was canceled. And not only was it canceled, but no one knew when it could be rescheduled. And all of the so-called non-essential clinics were being canceled. So we couldn't even see her in the clinic to see how she was doing. And her family doctor had closed her office because the family doctor couldn't procure appropriate personal protective equipment like masks. So here's a patient who was waiting for a potentially curative procedure, who was essentially abandoned by the system in the chaos in the early days of wave one. So just imagine how she must have felt. The second case is a case shared with me by a colleague who works with me in Kingston. This is a 79-year-old man who'd had increasing pain in his left knee. He was diagnosed with osteoarthritis. So this is the common kind of osteoarthritis that we see in middle-aged and older people. Saw a surgeon. The surgeon did some x-rays and an exam, said the joint was bone on bone. In other words, all of the cartilage and other tissue had eroded away, as is characteristic of osteoarthritis. And in January of 2020 was listed for a knee replacement, just like thousands and thousands of other Canadians every year. And this man felt quite lucky when he was given an April date, because he'd heard lots of people wait much longer, months in many places. So he was quite optimistic about this, figured he could put up with the pain a little bit longer. But then just like my patient, he got a call in mid-March when everything was shutting down, telling him that his procedure had been canceled and no new date offered. So again, just sort of a cutoff from the system and given a message, stand by until we can figure out what's going to happen next. And then the third one, this is shared with me, shared by another colleague. And this is one that I think is particularly telling. And that is a 45-year-old single mother of two who's holding down two jobs to make ends meet when she noticed that she just wasn't feeling right. Her family doctor did some blood work and found a few very subtle abnormalities in her blood work, suggesting that the liver was a little bit out of skew. She had a FIT test, which is a screening test for blood in the stool, which showed that she did have some blood in her stool. And because of a family history of bowel cancer, her family doctor arranged for her, quite appropriately, to have a colonoscopy. She was scheduled for the procedure, but again, just like the other two patients, canceled abruptly in late March in the midst of the COVID crisis. No rescheduled date offered. And she, like the other patients, felt abandoned and alone. She was worried that she had cancer, worried that she would die and leave her children with no one behind. And so this communication gap and this sense of no confidence in the system, quite rightly, I think was really exacerbated in those early days of COVID. And the human stories behind these canceled cases, I think, really serve to highlight how badly we've failed patients. And this isn't to put blame on anyone, of course, because everybody was doing the best that they could. But as I hope we can discuss, there are some solutions now as to how we can do better in the second wave, and particularly how we might clear this backlog in a fair and equitable way that enhances communication and helps patients restore their faith in the system. So maybe I'll stop there, Peter, and we could, I'm happy to answer any questions you might have about those cases.
Dr. Simpson, thank you for those impactful stories. They really shed a light on kind of what the issues are and the challenges are. I do have a question. Would a central intake process help improve the situation for these patients and others across the country?
Yeah, the answer is absolutely yes. And central intake can be, I think, best understood if you imagine your customer experience in Walmart. So 20 years ago, when you went into Walmart, there would be, say, 8 checkout counters, and there would be 8 individual lines lining up for each of those counters. Today, though, if you go to Walmart, there is one single line. And when you get to the front of that line, you go to the next available checkout counter. So the number of checkout counters is the same, the number of customers is the same, but the efficiency becomes much greater. You can get a lot more people through per unit time if you do this common intake model. So the same thing applies in healthcare when you have a wait list for a procedure like, say, knee replacement. So if people are in a common queue and they're willing to go to the next available provider, then we can squeeze another 20 or 30% efficiency out of the system. So this requires a coordination of the system. It requires electronic tools in order to be able to manage it. And I think John will explain a little bit later how the Novari solution can facilitate this kind of model.
Great. Well, thank you. That's a very simple explanation and very easy to understand. So thank you. I do have another question just around looking at hospitals and regional health admins, and they're really a struggle around getting real-time data, insights into wait times, at the surgeon level, at the hospital level, at regional levels. How does a waitlist management technology impact the healthcare system and the patient experience?
Yeah, basically, you can't fix what you don't measure. It's an old saying, but it applies as much in Canada in 2020 as it ever did. When I was chairing a group called the Wait Time Alliance a number of years ago, we publicly reported wait times on all kinds of different surgeries, procedures, specialist consultations, tests, etc. And it would shock you to know that the vast majority of medical and surgical care in Canada has no public reporting of wait times whatsoever. Mental health, for example, there's very little public reporting of even such simple metrics as how long it takes to see a psychiatrist after you're referred by your family doctor. So this non-transparency, I think, makes it very, very difficult for us to measure our performance. And if we can't measure our performance, then we can't make it better. A lot of surgeons still manage their wait lists literally on paper that's stacked on their desk. This seems hard to believe, but it's true. And if I'm a surgeon and I'm called by a family doctor and says, look, Mr. Smith, he's really having a hard time with his knee pain. Is there any way you can move him up? If I don't have a line of sight to my entire wait list to know what the story is, my response as a human is going to be, of course, I'll move him up. And that's going to make the family doctor happier. It's doing something good for that patient. But in a fixed resource environment, that necessarily means that somebody else is going lower on the list. And so without a dashboard or some way of knowing the entirety of the patients who are waiting, I wind up making decisions that inadvertently disadvantage other patients. So we need electronic solutions to ensure the equity and fairness that I think Canadians expect from their healthcare system.
Okay, I'd like to turn things over to John Sinclair and have him take us through what Novari is doing, and really in relation to what Dr. Simpson has shared with us. What the problem exists around access to care, right? So who in Canada is implementing kind of this new way of doing business or really leveraging new technologies to make things happen? John?
Yeah, thank you, Peter. There are pockets across the country where you mentioned central intake, and Dr. Simpson gave us a really good explanation. He used the Walmart comparison. I always use WestJet or Air Canada, but they do it for the same reason, because central intake works. It improves access to care for patients. So we see this in pockets. We see it in the prairies. We see it in British Columbia, in Ontario. But many of those central intake programs for mental health, for medical imaging, don't really have an enabling technology. So there's 3 that come to mind, 3 really good examples. These are 3 Ontario examples, as it turns out. But they're exemplary. And the first one I would call out is the Northwest LHIN, with leadership from Thunder Bay Health Sciences. They've actually set up a central intake program for hips and knees. But what they've done differently is they've set the central intake up so that all referrals for hips and knees, as was mandated, by the way, a few years ago across the province, come into the central intake office. They're managed using Novari technology. And then the case, if the case is a good surgical candidate, the patient is ultimately triaged, and then routed to an orthopedic surgeon who does hip and knee replacements. When the patient sees that surgeon, if there's consent to proceed to surgery by both, by obviously by the patient, but the surgeon also agrees to perform the surgical procedure, then that case is actually transitioned from what we would refer to as wait one, the referral wait time, to wait two, the actual wait time for the surgical procedure. And what they're doing that's unique in the Northwest is they're managing that whole continuum, the wait one and wait two, right from the beginning, right from the referral process from the GP, right to the day that the patient comes in and has the surgical procedure. And you asked about the data a minute ago. So imagine the data. They now know the referral wait time, the triage wait time, the wait time to be seen by the surgeon, and then the wait time for the surgical procedure. So I think the Northwest Lynn needs a shout out there. The other one that comes to mind is Mississauga Halton. That region, I think it's a population of 1.2 million people. They outside the hospital in a commercial complex, in an office complex, they've actually set up a regional central intake office or program. And that program manages all the referrals from within that area for diabetes, foot care, hips and knees, mental health, addictions, and they're looking at more. And why are they looking at more? Because they've proven that the model works. They've also proven, being an early adopter of central intake technology, that if you implement a central intake program and you don't have the enabling technology, it's not really scalable. So they're doing a fantastic job. It's innovation. It's not just innovation because they're using Novari technology. I mean, that's great for Novari, but it's innovation in how they're actually improving access to care for patients. And the third example, Peter, I would call out would be Ontario Health and the division formerly known as OTN, or the Ontario Telemedicine Network. So when the pandemic hit, they set up the OVCC, the Ontario Virtual Care Clinic, a walk-in clinic, but a virtual walk-in clinic for patients. Any patient in the province can log into this virtual waiting room, wait. Now, I've done it personally as recently as about 2 weeks ago for my own healthcare. I logged in. They are using Novari's virtual care technology, but within 15 minutes, I was able to have a virtual encounter with a primary care clinician, get a prescription, and that was all done on the weekend when I couldn't have access to my primary care provider. So that ties into one of the patient cases that Chris Simpson talked about. When during COVID, if you don't have access to your primary care because they didn't have PPE and they're not working the same hours and it's hard to get access, there needs to be alternative ways to do that. So yes, we're talking about surgical wait times, but really it's across that continuum of care. And so they're really good examples. Canada's the land of pilots. What we really need to know is we know what works. We have the technology. We need to implement them and implement them for mental health. Chris talked about not having the data for around mental health is a great example, but there are so many others. So we need to scale this out now and implement it because we know it works, we know it's cost effective, and we know it improves patient care. So those would be three examples.
Yeah, no, when you tell like that, that really is very impactful. So thank you. I do have another question here that's come in. What makes Novari's access to care technologies unique and so successful?
So a couple of things have made us unique. One is we're clinician driven. So we have folks like Chris Simpson and others that give us that clinical, they just infuse the clinical view of things into everything we do as a company. And I would say something else would be that we don't just focus on the surgical waitlist management piece, that wait two piece, but we look left and right of that. We look, how do you get access to primary care? How can we enhance that? And then how do you get a referral from primary care to the specialist, let's say through a central intake program, like hips and knees, or like medical imaging, or like mental health, like addictions, the list goes on. And then how do you track them during surgery? And then what about the post, being discharged from an acute care hospital, right? The patient needs to go go somewhere. They need home care. They're going on to palliative care, long-term care, complex continuing care. And how do you, I mean, in that case, the hospital's making the referral, but how do they get that patient to the right provider? I would also say, it's fundamental for us is that we don't really show up with a health authority in any province or a ministry of health or a hospital. We don't really show up and say, congratulations, you've just bought some software to implement central intake or surgical waitlist management or virtual care, and here's how you're going to run your program. In fact, we don't do that at all. What we do is we come on site and we look at your current workflows, current state, we look at future state, and then we come up with a plan and we configure the software to get to future state. And so it's not a take it or leave it proposition, because there are differences in how you would implement a central intake program across a vast rural part of Canada versus downtown Toronto, Vancouver, Montreal, and so forth. So it's being flexible, and I think at the end of the day, it distills down to this: we're just trying to get the right patient to the right provider at the right time. Now, everyone's heard that, but I think there's a fourth, and the fourth element is with the right data. You don't want to get, Peter, you don't want a referral to a surgeon of one flavor or another and wait 6 months or wait a year for that consult, and you arrive and then you're told, A, you're in the wrong place, I don't do what you need, or B, hey, we need to get an MRI. And so you're going to wait another 2 months now for the MRI. We can make sure that that sort of thing doesn't happen, and that you as a patient get to the right provider at the right time. That's that whole central intake thing, and Chris described that very well with the Walmart approach. But with the right data, your clinical data has got to travel with you, and it's got to travel securely. And so if you implement all of that, and you take all those factors into consideration, it boils down to improving access to care for patients, and just making sure the technology delivers on that promise.
Wonderful. Okay. Well, thank you very much. That's very telling in how you share that story with us. So with that, I'd like to wrap things up, and I want to thank Dr. Chris Simpson for joining us, as well as John Sinclair. And the stories you tell were very impactful and really told or hit home, I think, from my point of view and my perspective. So what I'd like to ask, for those of you listening, if you do have any other questions you'd like to pose to Chris or John or myself, please post them in the chat window or the IM window, and we can actually answer those questions for you. And just as next steps here, as we wrap up, if you start to look at the slide, you'll see that there's the contact information for Novari Health. You've got some contact information for Microsoft if you have any questions for us. So I'd like to thank John and Chris for their time. And any closing comments, gentlemen, for the discussion today?
I'll let you go first, Chris.
Sure. Well, I really enjoyed the discussion, and Peter, thanks very much for guiding us through it. I hope we've conveyed the message that John and I and others at Novari are very, very committed to our mission here. We really see this solution as something that can be a major contributor to not only resolving the backlog, but resolving some of the long-standing issues around access to care in Canada that have been problematic for so long. So thanks again.
Okay, thanks, Chris. John?
I'll just echo what Chris just said. That, these issues have been problematic for so long, but COVID has really brought them to the fore. And there's a desire now and a willingness, frankly, to change business models, and that's brought on by the COVID. So there'll be a long legacy of wait times coming out of COVID, which will take probably years to address. But I think there's momentum now. There's momentum for change, and we're seeing that. We're literally seeing that in every corner of the country.
Well, thank you. I think you're absolutely right. I think what you shared today is really a way to address this problem. And for those that would like to get more information, please capture that from the slide that you see in front of you. So again, thank you, gentlemen, and have a great day.